Welcome, everyone, to the latest presentation of the National Telehealth Resource Center's webinar series. These webinars occur monthly and are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of each month. We know today is not the third Thursday of October. However, we had some scheduling difficulties, so we moved it to today. Next slide, please. The 12 regional and 2 national telehealth resource centers are located throughout the country, and each serve as a focal point for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Next slide. A few tips before we get started. Your audio has been muted for today's webinar. Please use the Q&A button in the bottom middle of your screen on your computer or smart device. Questions will be answered at the end of the presentation. Today's webinar is being recorded, and you will be able to access it on the YouTube page for the National Telehealth Resource Center. Next slide. Today's webinar is hosted by the Upper Midwest Telehealth Resource Center and presented by Kristen Kelley, Project ECHO Program Coordinator for Indiana University. Kristen, go ahead and take it away.
Hello, my name is Kristen Kelley. As she mentioned, I am Program Coordinator for the Opioid Use Disorder ECHO program with IU School of Medicine. I'm located at the Indianapolis campus in downtown Indianapolis. These are just some of the few objectives that I want to go over that will be presented today. I'm basically going to describe Project ECHO as if you've never heard of it. Some of you are probably familiar. We'll describe it not only as a national basis, but also the Indiana project, examine some of the efficacies regarding Project ECHO, identify ways that to become involved in our program, but also how to maybe start your own program in other states or universities, and then identify some of the challenges that we have faced with our implementation. So Project ECHO originated with the University of New Mexico. There was a doctor named Sanjeev Arora with the University of New Mexico who was one of 2 prescribers or providers in the state who was treating patients with hepatitis C virus. And at one point, they estimated there were over 36,000 individuals in New Mexico that had hep C, but only 5% of them were actually in treatment. And so he was trying to figure out a way that he obviously couldn't see every single patient. So he wanted to try to figure out a way that he could treat some of his patients through telehealth. But then he thought, well, why not train some of these physicians and providers that are referring these patients to me on how to treat their own patients? So he developed Project ECHO. It increased community capacity, got people access to care, and created these healthier communities within New Mexico. And now there are over 550 separate ECHO programs located in 32 different countries, but training over 200 different complex medical conditions. So this program prevented patients from having to travel to the University of New Mexico or other locations and being able to be treated in their own communities. Project ECHO stands for Extension for Community Healthcare Outcomes, and their mission or goal is to democratize medical knowledge and get best practice care to underserved people all over the world. So it started, as I mentioned, University of New Mexico, and it's just kind of spread. So it revolutionizes medical education and increases workforce. It also shares best practices through a hub and spoke knowledge sharing network through telehealth or a virtual system. So we know that people need access to specialty care for these complex medical conditions all over the world, but there aren't enough specialists to treat everyone, especially in the rural communities. So it trains these primary care clinicians to provide the specialty care services through a web platform or Zoom technology, which you're all familiar with. And then patients get the right care in the right place at the right time in their own communities. So it moves knowledge, not patients, and kind of basically a force multiplier. So the ECHO model, just kind of the ABCDs of ECHO model, we use technology to leverage scarce resources, to share best practices. And then one of the focuses is case-based learning. So using real-life patient scenarios to learn. And then there's a database called ECHO, which monitors outcomes and number of participants and how you are effectively transporting that information throughout the state or country, if you will. So this is just a map that shows the ECHO hubs and super hubs across the United States. We, like at Indiana University, is a hub. Super hubs are basically hubs that are working together to multiply that even quicker, like one hub sharing hubs with information with several different hubs. So it's kind of a trickle effect. But this shows the ECHO programs all over the country. So like Argentina has a program, Kenya, Australia, Scotland, England. These are all different complex medical conditions. When I went to the immersion training, there were people there from all over the US and the country looking at Hep C, diabetes, opioid use disorder. There were some even really, really like very specific, one on pediatric migraines. So you really can use this model for any disease or medical condition. So the concept is an all teach, all learn model. So community providers learn from specialists, community providers learn from each other, and then specialists learn from community providers as best practices emerge. So the great thing about ECHO is it really is very adaptive to your audience. So if you figure out that your audience wants to learn about something particular, wants to talk about something particular, you can kind of adapt the education to that model. So we are finding that a lot of our specialists are actually learning from other people out in the communities about certain kinds of medications that might be being abused or other forms of best practice. So this helps patients get access to care without leaving the providers that they trust in the communities where they live and work. For example, I was thinking about this yesterday when I was going to my hair appointment. I live in a suburb of Indianapolis, and my hairdresser just moved to another suburb of Indianapolis, but due to traffic, it takes me almost an hour to get there and an hour to get back. So I was thinking about how that would be for folks that are trying to just get medical care for themselves, or those that go to a methadone clinic and may have to travel that same distance every single day to get methadone. So, I think this approach is helpful so that people can, get the care they need, where they need it, when they need it. So it allows for the spread of medical expertise from specialists to those primary care providers and their patients. And hopefully, over time, those primary care providers in their communities will become experts in this field and can share the knowledge with other providers in their community. So one question that we get a lot is, what is the difference between ECHO and telemedicine? So I'm sure you all are familiar with telemedicine. Traditional telemedicine is a specialist, manages a patient care remotely. But through ECHO Clinic, it's an expert hub team that mentors other spoke sites out in the community, so primary care teams. So in some cases, you may have one provider that connects in on Zoom. Other times, it's the whole clinical care team in that particular clinic that will be involved. And then that information disperses, to the patients through their knowledge and expertise. So, we address a lot of system challenges like access, insurance barriers, quality, dissemination of best practices through this, force multiplier approach. One thing that Project ECHO, some of the outcomes that have been evaluated and found to be true, that it increases knowledge and competence and confidence in treating patients with these complex medical conditions, improves access to care, and obviously improves patient health. And a big thing is that probably a secondary outcome that maybe we weren't expecting is increased job satisfaction. So people that are treating patients with complex medical conditions such as opioid use disorder, the patients, their issues stem way beyond the just medical aspects. There's a lot of socioeconomic barriers, there's stigma barriers, transportation barriers. So, sometimes these patients can seem exhausting, if nothing else. So it really does kind of help from feeling burnt out, but also there's a less of a feeling of job isolation. We try to make this like a cohort, and folks that you can rely on and depend on, and share experiences with, in a confidential setting, and share that knowledge so that you feel like you're not the only one out there treating these patients. This is just some information behind some of or proof of some of the outcomes and some of the studies, which will be on the slide set that I will share. So just in Indiana, this is just kind of identifying what the opioid crisis looks like here. The left depiction shows visits due to opioid overdoses, and then on the right, it's drug poisoning and opioids due to opioids. And, Indianapolis and some of the urban areas, just shows that this disease does not discriminate, that there's a problem everywhere throughout the state. So we need treatment providers everywhere, not just in those urban districts where there's a university or not where there's major hospitals, but, especially in some of the rural areas. And then this graph shows some of the medically underserved areas regarding providers, physician and providers on the left, and then mental health professional shortage areas on the right, which are very, very extreme throughout the state. The Indianapolis area in the middle, up on the top left is the Chicago area, so it's not as desolated, the Louisville area. So some of the more metropolitan areas have all of the needed professional or mental health providers, but it's those rural areas that don't, and that's why we have to get that information dispersed out to those communities. So some of the barriers, I want to kind of transition to specifically to opioid use disorder and treatment. So barriers to opioid use reduction in Indiana. Some that we've found are, patients are reluctant to engage in evidence-based treatment due to stigma, not only in the community, but also among treatment providers. There's still not a lot of education going out to treatment providers specifically about medicated assisted treatment. Many think that it really is trading one drug for another, when evidence shows that it is, a way to successfully get people into opioid treatment. Lack of coverage for many treatment and supportive services. There's still, not a lot of the medicated assisted treatments are covered by Medicaid or some of the insurance providers. More of them, still provide coverage for all the opioids that they want to take, but not for some of the treatments in order to help with the addiction. Telehealth still isn't covered in a lot of Medicaid or a lot of MCOs. Then we have community stigma, as I mentioned. Some of the patients still have trouble going to AA meetings or support groups because they are being stigmatized for using a medicated assisted treatment, for example. So I think the more that we can share information about stigma reduction and how to treat this condition like any other disease, the better. So that's, one of the things that we really try to focus on is, proper, how our words are important when it comes to treating opioid use disorder. Transportation, which I mentioned a couple times, makes it difficult. A lot of opioid use disorder patients have criminal histories and therefore don't even have driving privileges. They live in rural areas that don't have public transportation. So getting up to urban areas for treatment isn't always feasible. In Indiana, we only have 15 methadone clinics in the entire state. So, and some of them are concentrated in the urban areas. So it's really challenging for those patients to get to their methadone clinics every day. So other forms of treatment are necessary in order to treat this disease. Lack of collaboration among providers. One thing that we're realizing in our clinics is that the providers don't talk to the prescribers, who don't talk to the folks that are, prescribing the Suboxone, or the psychiatrist. So just trying to create this more integrated system of care is what is also another positive outcome for ECHO. And then inadequate funding for treatment and supportive services has always been a challenge in this disease, treating it and funding it like any other healthcare disease. So specifically talking about our track, we were awarded 21st Century Cures funding through Indiana Family and Social Services Administration, which is our Division of Mental Health and Addiction, late fall of 2017. I was actually brought on board in February of 2018, and then we started our program in March of 2018. And we partner with several organizations, IUPUI, which is our School of Public Health, and then the School of Public Health down in Bloomington. So it's kind of a collaborative effort. We also have some other ECHO clinics that we work with. There is a Hep C clinic and an LGBTQ clinic. So we all kind of work together and share best practices. So the current tracks that we have in Indiana, and these are specifically related to care and treatment of opioid use disorder, is our Prescribers and Dispensers track, which consists of physicians, nurse practitioners, physician assistants, also pharmacists, who are planning to obtain their waiver to prescribe or dispense buprenorphine. It's not necessary, and some of them are in the process of getting the waiver, and some have already gotten the waiver, or some are thinking, I might want to treat patients with opioid use disorder. What would I need to do before I get my waiver? So for those of you that aren't familiar, it is a waiver that's, or a data waiver that's given by SAMHSA. Physicians are only required to get 8 hours, and nurse practitioners and physician's assistants have 30 hours of education to get this waiver. And I mean, we know that 8 hours isn't sufficient in order to treat this complex condition. So I think that's why ECHO is so important, to supplement what might not necessarily be taught during this waiver process. And then, so the prescribers and dispensers meet Wednesdays from noon to 1:30. We just met a couple hours ago. Then we have a behavioral health specialist track, psychologists, social workers, counselors, who are also treating clients or patients with opioid use disorder. They meet Thursdays from 1 to 2:30. And then community health worker, which includes peer recovery coaches and specialists, community advocates, patient navigators. There's some nurses or office coordinators or office like staff in prescribers' offices that also are involved in this clinic, just trying to figure out how to direct patients to certain resources. So they meet Thursdays from 9 o'clock to 10:30. And all of our sessions are based on, our tracks are based on 12-week sessions every other week. So a total of 24 weeks, but 12 sessions. And they meet for 90 minutes. And then I just want to kind of go through and break down the anatomy of an echo clinic. As I mentioned, it's confusing because we went recently from weekly to every other week. We felt like every other week gave folks a little more time to apply what they were learning. And so I probably need to amend the slide, but it is 12 sessions, so they will fall under a 24-week period. Meet every other week for 90 minutes using Zoom technology. Hubs, which are the experts, meet in one location. So if you can kind of see this graph here in the top left-hand corner, this is our hub site, and they all meet on our IU campus. And then the spokes, which are the community providers, log in and are out in the community. So each session is started with introductions, but not only by the participants or the spoke sites, but also the experts. It does take a little bit of time at first, but once you have a couple sessions, it goes pretty quickly. People start to recognize each other and know each other, and it's important for people to really turn on their videos so that, I think it creates more of a collaboration and more of a community feel, so you can get to know each other and maybe communicate outside of these clinics. We do a 20-minute didactic on a particular subject, and then question and answer on that didactic, and then one to two patients' case presentations. So as I mentioned before, one of the main focuses of ECHO is case-based learning. So we do a case, and I'll talk a little bit more about that in a second. This is an overview of our legal experts on our panels, and it is not true for all of our tracks, but for the most part, we have one of these representatives on almost every track. So the medical legal piece has been really crucial. We have a legal expert on our panel who talks a lot about some of the legal challenges that OUD patients face, such as discrimination or child support, some of the criminal issues, advanced directives, like what to recommend to your patient if they are in a car accident and they have to present to the ER, and whether they should or should not be given opioids because of their past history. So he gives folks a lot of things to think about, and there's no better advocates sometimes for their legal issues than their medical providers. And he talks about how you might want to how you can advocate for your patients. And then one of the psychosocial interventions, we have a psychologist on each of our panels who talks a lot about cognitive behavioral therapies and, pre-contemplation stage and how to move people into the contemplation stage if they're thinking about, getting into treatment. Peer recovery support is crucial for all three of these panels. Just the perspective of what it's like for someone to be in active recovery and also active addiction, and just kind of getting into the mind of them. They've been, very important part of this, and also how important it is for folks to have peer recovery support. And when they're getting into, treatment, we talk about treatment. A lot is focused on the treatment, but it's the recovery piece that is the biggest part of somebody's journey. So how to maintain that recovery and how to get that support those folks need. Addiction psychiatrists to talk about, to relate some of the co-occurring medical conditions that's associated with opioid use disorder, such as anxiety or ADHD, bipolar. A lot of folks with opioid use disorder have other co-occurring mental health conditions or physical conditions. We have an outpatient and inpatient psychiatric pharmacist who talks a lot about drug interactions, specifics about medicated assisted treatment, the pros and cons of using a particular treatment in a particular individual. Internal medicine, prescribers who actually treat and prescribe medicated assisted treatment out of their primary care offices, and then also social work and case management and talking about change talk and just getting people connected to the social services that might be needed in order to help support their recovery. This is just a picture of one of our expert panelists. This is the community health worker track. Some of our learning objectives. This one's just for the prescriber and behavioral health track, which are very similar, talking about the neurobiology of opioid use disorder, what causes someone to become addicted to a particular substance, but maybe not someone else. So talking a lot about the brain changes, things that happen in the brain, genetics, and how that factors into opioid use disorder. Of course, assessing and diagnosing opioid use disorder, how to talk to your patients about it, experts, screening and brief intervention is a big part of it. How to manage patients with opioid use disorder in your practice, talking about specifics like urine drug screenings, pill counting, contracts, why it's important to have contracts with your patients, how to look for drug diversion in certain patients and why drug screening is important in those instances, and just sharing those individualized treatments. This is just another view of, I use the slide set for folks that aren't familiar with Zoom and how it works and how easy it is, but this is another, our behavioral health track, and then here are the spokes up in the top. One thing that I like to emphasize a lot is that continuing education, this program is free for our providers and our participants. As I mentioned before, it's funded by 21st Century Cures money. So we offer free continuing education. Community health workers and peer recovery supports are a new certification based in Indiana. They're actually now being reimbursed through Medicaid for some of their services. So there is continuing education required by ICATA, which is our coalition of Indiana Addiction Coalition, and then Mental Health of America. Then, of course, our behavioral health track. We provide behavioral health CE for all of those professions, as well as CME for physicians and physician assistants. And then here is an example of our curriculum for our community health worker and peer support track. We have a different one for behavioral health and a different one for prescribers. Some of them are the same, like for instance, Introduction to Opioid Use Disorder, but we try to educate each of the groups on the different roles that people have within the integrated system of care. Stigma reduction, as I mentioned, we have a whole separate presentation on stigma reduction and why the words we use matter, why you shouldn't say that someone is clean or dirty, substance-free, or is a more appropriate term. Evidence-based treatment and medicated assisted treatment, harm reduction strategies such as naloxone and syringe exchange services, as well as why medicated assisted treatment is considered a harm reduction strategy. I went into detail pretty thoroughly earlier about why it's important to talk about the legal matters, motivational interviewing, And then we also talk about specific resources that are available in Indiana, such as recovery housing. In Indiana, we also have a service called Recovery Works, which provides, it's like a pot of money that is available only to felons, but it kicks in if someone doesn't have HIP or insurance, but it provides housing, transportation to treatment. There's a whole list of things. So we try to educate folks on how to become Recovery Works providers and apply those funds to those services. Crisis intervention is big, and then also how to re-engage the folks back into the community and get them involved with their family and loved ones again, instead of remain in isolation. This is a sample of our curriculum for prescribers and behavioral health. The great thing about the ECHO model and ECHO Institute is they do have curriculum that they've come up with that you can adapt and alter or change to make it more specific to your state and your state guidelines or laws. But this is just an overview of one of the tracks for our prescriber track. And then we do an evaluation piece after each session. We do a pre-evaluation prior to the entire 12-session track that asks questions such as, what is your awareness of opioid use disorder, or how comfortable are you diagnosing opioid use disorder? What is your confidence level? How comfortable are you with motivational interviewing? So we ask that prior to the 12-week track and then post 12-week track. And then we also do ask evaluation questions after each session to just kind of assess, each particular topic and whether they'll be able to apply those subject matters to their individual practice. This is just a sample or example of one of our didactic presentations. So it just shows how we share the PowerPoint, just like I am in this presentation, and then everyone can still see each other on the right. Here's another one, which is for behavioral health. I just kind of try to show this to folks that aren't super familiar with Zoom. Okay, I'll delve into a little bit on the case presentation. So as I mentioned, this is case-based learning. At first we tried to do 1 or 2 cases per session, but honestly, these cases are pretty complex, so we've only been able to get through really 1 per session. But a participant, which is a spoke out in the community, one of the providers will present a de-identified patient case, so there's no patient or protective health information shared. They'll present all of the information related to the patient, which I'll show you another screen here in a second that kind of shows a little bit more about what I'm talking about. But then everybody out in the community will have a chance to ask questions, and then the experts will ask questions, clarifying questions. And then both the spokes and experts will have the opportunity to make recommendations, share their knowledge and best practices. And then written recommendations are, we come up with written recommendations that we share with the participant to help them guide this patient down the road. And then we encourage the participant to come back and share with us in the future how this patient's doing, any follow-up, any further questions about this particular patient. So this is a sample case presentation form, something that we would share during clinic that shows just some general information about the patient, their opioid use history, as well as other medications that they might take, such as benzos or medication for other chronic healthcare conditions. Also talk about what insurance they use, where they live, if they have any strength or other protective factors, what some of their weaknesses are, what some of their other challenges are. And then we list the main questions that they have specific for this patient case. Oops. Oops, sorry. And then I just wanted to show kind of a breakdown of where the participants are located throughout the state. So prescribers, those that are participate on our prescriber track are identified in red. Those in our behavioral health specialists are blue. Green, our community health worker track. We've had 153 total participants. We've had 2 prescriber tracks so far, 1 behavioral health track and 1 community health worker track. So really 4 tracks. So I feel like this is a pretty good, we've had pretty good participation amongst all the tracks. 34 participants completed 75% of the sessions, which I don't think that's one thing that I touched on, but we don't require someone to sit in on every single session. So we know that that's not really practical with everyone's schedule. So we try to schedule them out so everyone knows, and we mainly do it on lunch hours so that people have the opportunity to take a break and maybe eat their lunch and participate. But we know that it's not practical for everyone to go to every single one. So the CE that is offered is for each particular session, not the overall session series. And we average about 25 participants per session. The ECHO model is no more than 30 roughly, just because of it starts to feel less like a collaborative network, and it's harder to manage. So around 25 per session. Benefits to participants that we found just through some of our evaluations is, of course, the no-cost CE, more professional interactions with colleagues who are treating similar patients, people that are reluctant to maybe get into this field are being able to share their thoughts and, hesitations with this group. So that's been really helpful. Resource sharing has been huge. People have been able to collaborate outside of clinics, sharing, some treatment options or treatment availabilities with each other. We share the participation email list, so everyone are able to contact each other outside of clinic. And then, I don't know about other states, but Indiana, we have only 4 addiction psychiatrists in the state, and one of them is participating in this ECHO. So just access to, one of the very few addiction psychiatrists in the state, being able to provide, consultation with some of their patients, I think is a really valuable asset. Another thing that I didn't think about till after I made the slide, but was, one thing that we're really identifying in these sessions is barriers and lack of treatment, lack of resources for patients. And so one thing that we're able to do is, advocate for more funding and more treatment options, because we're able to, we have folks from all over the state that are treating for opioid use disorder and seeing, the same problems keep coming up every session. There's not a whole lot of communication, or there's so much isolation even among providers, that just trying to advocate for more system of care funding and treatment for this disease, I think is going to be really beneficial in upcoming legislative sessions and talking to policy directors. This is just some of the things that people are saying about ECHO and our evaluations. Being able to develop a network of from other providers, getting the panel to weigh in on difficult cases has been really helpful. Didactic sessions and suggestions were very informative and helpful, getting greater confidence. And then here are just some specific quotes. The top one was from our community health worker track, where she had a pregnant patient who was trying to get health, care for her pregnancy, like her prenatal care, and was having difficulty. So they were able to connect this young lady to another resource that she didn't even know existed. And then this is just a becoming involved slide, how I let people know how they can sign up for our ECHO clinic, and they just need to do the short survey that I mentioned, the post or the pre-survey, and there's a confidentiality agreement that they would need to sign. That's our website. This is just a screenshot of our page that shows you how to get involved. One great thing about ECHO is that we, as I mentioned, share resources. Any of our presentations are put on our website, as well as any links or articles that we bring up during session we post in our library here. We also have on our team page, an expert page, show all of the bios of all of our experts. And then here are some of our future tracks, as I mentioned, through some of our partnerships with other IU schools. We have the Hep C clinic. We also have the LGBTQ clinic. We are focusing this next prescriber clinic on OUD and pregnancy. We're going to start an OUD and adolescent series next year, or late this year, early next year. Then in 2019, getting more into pain management. A prison educator Hep C series, which looks a lot different, but it's educating those inmates in prison on how to become experts in Hep C education and awareness. So once they are released, they can help be an advocate for, becoming or from sustaining from activities that would make you vulnerable to Hep C. Endocarditis, which is a disease that comes along with opioid use disorder. Peer support, specifically in ER settings, is going to be one of our major focus, and then on first step workers, and then 2020 school nurses and diabetes, especially among community health workers. And this is just our main OUD ECHO page that is able to connect you with some of the other services or other programs in Indiana. So I want to talk a little bit about replication steps. If you were interested in starting an ECHO program in your state, you would probably get more information directly from University of New Mexico, but there is an orientation that you can attend out at New Mexico that just gives you like a one-day quick overview on what it would be like to start a clinic on a particular disease or medical condition. There are partner documents you would need to sign, confidentiality agreements, so that you don't share that information with other resources. Funding is a huge thing, but honestly, ECHO is a pretty relatively cheap way to address workforce issues. We pay our experts and then my salary essentially, but the rest of the salary really just goes towards outreach and advocates advertising materials. So there really is very, very little funding involved other than those particular line items. One thing you would need to do is design your project, like who would be your target audience, curriculum, resources. As I mentioned, ECHO has a lot of those materials. Steal and duplicate is basically one of their mottos. So I kind of designed my program based on one that was in Oregon. They had a prescriber track in Oregon, so I relied heavily on using a lot of their materials and information, and of course developing your team, experts, and staff. And then once you do all that, then your team would go to a full day training out in New Mexico. It's a 3-day immersion training, which really delves deep in how to run an ECHO clinic, the pros and cons, and do's and don'ts of a particular ECHO clinic, which is free, other than you have to pay for your hotel and travel. So that is another expense actually to funding your ECHO program. I already mentioned curriculum, beginning to recruit spokes and participants, which is huge. I mean, you can't have an ECHO if you don't have the participants. So just collaborating with your associations, getting the word out to any and everyone. I'll talk a little bit more about that. And then you would do like a practice launch and get feedback from the ECHO Institute and other folks on your team, and then you would actually launch. And then quality assurance is constant, so trying to look at ways to evaluate the process. We're actually doing a IRB study too on some of our prescribers on looking at their treatment and the ways that they refer and diagnose and treat opioid use disorder prior to starting the ECHO clinic, during the ECHO clinic, and then after the ECHO clinic. So that's one of the things that we're in the process of doing right now, and hopefully we'll have information to share on that study in the very near future. Disease selection, likely you already know what type of diseases are problematic in your communities or your states, and you have a particular area of focus. So it's kind of looking at those as a way to kind of select what you want to do. Some of the challenges, as I mentioned, are funding. Even though it's not super expensive, there is definitely funding involved. I think the part of the national opioid bill talks a little bit about telehealth, and also ECHO is an option, and also there are a few states that actually have ECHO in a line item. I think New Mexico and Missouri have it in a state line item as funding, putting funding towards ECHO. Recruiting experts can also be huge. As I mentioned, we have 4 addiction psychiatrists in the entire state who are super, super busy. Getting them to take 2 hours out of their week or out of every other week to spend on an ECHO clinic, is sometimes challenging. So being able to recruit experts and the right experts, the experts that can actually teach and be helpful, is huge, and that believe in all of the evidence-based practice. Recruiting participants, case presentations can be challenging, getting people to actually share and present their case. Another reason why we moved to every other week, it gives them more opportunity to, as I mentioned, apply some of the practices they've been learning, but also start to treat those patients and be able to present challenging cases or scenarios and bring those to the experts. And then evaluations and quality assurance. Thankfully, that's not my area of expertise. We work with the School of Public Health in Bloomington, which is Indiana Prevention Resource Center, and that's what they love to do, is evaluate and do studies. So it's important to, I think, collaborate with somebody who really has that focus. And then we work with spreading the word and recruiting, and this is, just getting involved with a lot of your associations. I'm doing quite a few trainings around the state at conferences. There's a public health conference tomorrow. There's a Attorney General's Office symposium in a couple weeks where I'm presenting and just doing a table and outreach, trying to promote it that way. Social media has been big. We have a Twitter page and Facebook, so promoting folks that way. Also, I'm working with our medical school alumni association, so that's been a really good avenue also. This is my contact information, and I'd be more than willing to talk to anyone individually. Also, anytime that you want to, we'd love to have any of you sit in as an observer to one of our clinics, and just kind of gives you a sense on how they work, and whether you want to get involved or start one in your state, or participate in one in your state. And then I think time for questions.
Thank you so much, Kristen. We do have a few questions. We'll start with a really easy one. How many sessions into the 12 are you, and how many participants usually show up?
So we've actually finished 2 whole prescriber series. We're starting another prescriber track on October 31st. Each of those sessions have been around 16 people per session. Like I said, they don't all sit in on every single session. Some come and some go, and some might be there a couple weeks, and we might not see them, for 3 or 4 more weeks. So they get the curriculum and the schedule ahead of time. So if there's maybe a topic that they are more interested in, they might sit in on that. We also record the session so they can go back. The CE only applies, though, during a live session. Our community health worker track, we are in the process. We just are like 5 sessions into our very first track. And then our behavioral health track, we've completed a 12-week track, and we're 3 sessions into our second track. So I know that sounds confusing, but.
No, it makes sense.
Okay. So we have funding for, we're hoping 4 years. So what we just want to continuously offer these tracks throughout.
So next question, what does a MAT ECHO program look like for a rural area? Would people seeking treatment meet together with a provider or at a site, or is it individualized for patients who show up? Just curious. So
ECHO is only for providers. So we have providers that participate in our ECHO from all over the state. So we are located in Indianapolis, but for example, we have a provider located in northern Indiana, one from southern Indiana, west, east. So they log in at the same time. So there's no patients on our sessions. And then once the prescriber learns those best practices and feels comfortable enough to treat patients in their own communities, that's when they would meet with the patients. They may bring a particular patient case to one of our ECHO tracks for expert advice and opinion, but there's no, you don't need like a separate ECHO for a rural community. You can have one ECHO for the entire state and reach everybody.
Great. Do participants have to join an ECHO in the state in which they are licensed or practicing? And how about in order to earn CME CEUs?
We don't have any like rules against somebody in another state participating. We have had some folks that were involved in a managed care company and a telemedicine clinic, actually Genoa Healthcare, be involved from New York, be involved in our ECHO. So I don't think that we have any hard and fast rules on that. Other states might. And I'm not exactly sure how the CE works. Our CE is granted by Indiana School of Medicine. I think they would be transferable among states because they're also, they are designated by the American Medical Association to offer those CEs. So I'm guessing they would transfer, but I'm not 100% sure.
Okay. Let's see, let's we do next. You mentioned some studies and some were included in your slides. Are you familiar with any studies that have been able to quantify patient outcomes or cost savings through Project ECHO?
I am not. I would have to do some research on that. That is kind of what we're trying to do with this IRB study, is to quantify patient outcomes and to determine whether someone is more likely to recognize opioid use disorder. That's interesting thing that keeps coming up in our sessions is stigma. And we actually had a prescriber on our track that said, I don't know what to do. My office staff is adamant about not wanting to help these types of patients. And one thing that we've tried to say is opioid use disorder is probably already very prevalent in your patients and that you're already treating for other medical conditions. and you just don't realize that they have an opioid use disorder. So trying to screen and identify and how to talk to your patients is really challenging for a lot of providers. So, trying to quantify, how likely are you to be able to assess and diagnose these opioid use disorder in your practice prior to ECHO, during ECHO, and then after ECHO. So that's kind of that's all that we've kind of, as far as we've gotten on it. I'm sure there are national studies on that, and I can try to pull some up and share them with you to distribute.
Okay, great, thank you. This next one deals with federal opioid legislation. There has been some that has recently passed in the Senate and the House. The bill's been sent to the President for signature, and it does include some telehealth as part of the solution. So do you think that this legislation will help make a difference?
We actually just got an email this week from Dr. Aurora, who I mentioned was the founder of Project ECHO and is still really, really involved in Project ECHO, which has now become like a huge institute down in the University of New Mexico. But he sent a copy of the federal legislation and suggested that we all reach out to our legislators and really promote Project ECHO as an option for telemedicine or telehealth. And so I think it is going to make a difference. And as I mentioned, there are a couple states that have been able to create line items. And I don't know if there's any overall funding available specifically for telehealth. I need to really look into that further. But my sense is that there will be. I mean, ECHO is really kind of becoming more of a national household name, and I think it's going to be something that a lot of folks are going to be using as not only maybe offering more reimbursements or credentialing for those that have completed ECHO programs too. So I think there's going to be more funding available.
Mm-hmm. Thank you. Okay, so one final question. Someone is struggling trying to get a provider in Richmond, Virginia, to coordinate with another provider for the patient in rural Virginia, and they're having some difficulty with portals and those types of things. What kind of advice can you offer them?
Oh gosh, I don't really know about that, considering I know there's a lot of public health information and probably certain portals and systems that would be PHI and HIPAA accredited. So I'm probably not the best person to answer that. I'm sorry.
I would take a shot at it and say that maybe somebody from the Richmond office could actually travel and try and somebody with some IT experience could go down there and try and help them out. But I don't know. It's hard to say. There's so many different health IT platforms. So
yeah, and here's just my email again. So if any of you are interested in participating in one of our ECHOs, just to sit in on it and observe or participate, we always are looking for people that have, this is probably the 30th ECHO at least I've sat in on, maybe more, probably more like 40. And every single session I learn something, and something new comes up every single time. So it really is amazing, some of the dialogue that's happening among providers and some of the, I think, collaboration and camaraderie that people are feeling really a lot better about, going out there and fighting this epidemic.
Mm-hmm. Mm-hmm.
So.
All right. Well, thank you once again, Kristen. I really appreciate your time today and sharing with us. This is such an important issue all across the nation. If you would go ahead and advance to the next slide, I just wanted to let you guys know that our next National Telehealth webinar will be presented by the Telehealth and Technology Assessment Resource Center, and it will be the third Thursday of November, on November 15th. And on the next slide, we do have a survey that we ask everyone to complete for us. And Ray, are you going to go ahead and put that in the chat?
The survey should take our participants straight to the, our Zoom platform will take them straight to the survey right after they exit out.
Okay, great. And Ray, were you able to figure out the topic for the November session?
Yes, so I just got confirmation this morning that TTAC will be presenting, and their topic is titled Video Platforms.
Great, great. So if you, when you registered for today's session, if you said that yes, you wanted to be informed on future webinars, then you will get an invitation to register for next month's session. So again, Kristen, thank you so much. Everyone have a great week.
Thank you. You too.